5,000 new cases of head and neck cancers with 11,000 deaths. And in the US, this represents approximately 3 to 5% of US cancers. However, head and neck cancers are the sixth most common cancer worldwide, with high incidences in India and China for a variety of environmental reasons and exposures. There is a male predominance, about 2.5 to 1, male to female, and they're more likely to be diagnosed in people greater than 50 years of age. And most cases present with locally advanced disease. And what locally advanced disease means is essentially that there's a primary tumor either in the tongue or the tonsil or somewhere in the head and neck, and there is some lymph node involvement, because that's generally how these cancers tend to spread, at least initially. Now, as I mentioned, the HPV association with oropharynx cancers was found over about the last decade or so, and this represents one of the more exciting targets for treatment. It represents a distinct epidemiologic entity. HPV-related oropharynx cancer patients, they just tend to do better. They have a better prognosis. They do better with treatments compared to patients whose cancers are HPV negative or related to heavy alcohol or tobacco exposure. It is now thought that despite what was the trend maybe 30, 40, 50 years ago, nowadays 60 to 80% of oropharynx cancers are positive for HPV infection, which is a sort of a different trend than what was expected previously. Now, as is true with a lot of viral infections that cause cancer, the HPV infection employs particular oncogenes. So oncogenes are genes which normally transform a normal cell into a tumor cell. Now, these can inactivate proteins that normally suppress tumors. So if you inactivate something that suppresses a tumor, then the tumor can grow. And this is what HPV can do in the oropharynx, similarly as it does for cervical cancer patients as well. These oncogenes are going to be discussed a little bit later, and they are very exciting areas for the development of new treatments. I've tried to simplify a bit the general treatment paradigm for head and neck cancers, just because it is, only 3 to 5% of U.S. cancers, and I think a lot of people don't have a good framework for how these cancers get treated. Now, early stage disease tends to be treated with a single modality, and that's either radiation alone or surgery alone. And they tend to have a very good prognosis because of its early stage. It's found very early. The functional deficits that are resultant from either radiation or surgery tend to be well tolerated. If it's locally advanced, so I mentioned early stage, sorry, if oral cavity tumors tend to get managed surgically. The way I think about it, and especially when I'm teaching fellows and trainees, is if you can see it or grab it with your hand, that's probably something you can more easily cut out. So tongue, you can see on an exam, you can grab it. It's very surgically accessible. So those patients tend to get treated with surgery alone, or surgery plus or minus other therapies later on. If it's harder to see, so something like the nasopharynx or the base of your tongue or the tonsil, it's really hard to access for a surgeon. So generally that gets treated with radiation plus or minus chemotherapy. For locally advanced disease, again, as I mentioned, there's a primary tumor and that tumor has spread to the local lymph nodes. Those usually get managed with radiation plus chemotherapy, or if it's an oral cavity tumor like a tongue cancer, surgery, and then followed by chemotherapy and radiation. This represents an intermediate prognosis in contrast to early stage disease. Now, in particular, when we treat patients with oropharynx cancers, again, that means tonsil or base of tongue, those patients get treated with combination therapies, and the radiation is actually about 6 to 7 weeks long. So Monday through Friday, patients come in, come out, get radiation, and then usually once a week or every 3 weeks, they get chemotherapy along with it. So it's a pretty long treatment paradigm for patients with locally advanced disease of the oropharynx. So it's not a kind of one and done approach. It's clearly a hard, intense 7 weeks of therapy. The chemotherapy that we usually add to help radiation is called cisplatin, and we really add chemotherapy for 2 reasons. The first reason is to help radiation work better. So it acts as a sensitizer for radiation. The way I think about it is it kind of damages those cancer cells that are there, thereby making it easier for radiation to completely destroy the cancer cell. The second reason we do it is because whenever we see locally advanced disease, we worry about any sort of microscopic cancer spread somewhere else in the body. So if there's a teeny tiny microscopic cancer cell in your big toe, because radiation only kills the cells that the beams go to, chemotherapy goes everywhere. So chemotherapy ideally would prevent or quell the growth of that cancer. The reason that becomes extraordinarily important is because the moment that any cancer is seen outside of the head and neck, it's not something that we can necessarily cure. And so that's why it's very important to be aggressive with any sort of management of locally advanced disease. There is some controversy and ongoing studies in the field for whom chemotherapy can be avoided, even for locally advanced disease. As I mentioned, before 10 years ago, we didn't really even know that HPV caused oropharynx cancers. And so when they did clinical trials, they kind of lumped everybody together. But those patients just do so much better. So what I'll talk about in the next few slides is about de-escalating therapy and how to figure out ways to not throw the kitchen sink and really aggressive and really hard to tolerate therapies for patients who may or may not actually need it, especially for those patients who are HPV positive and who have 90% plus cure rates anyways. Cisplatin is a hard chemotherapy to tolerate sometimes. It has some unique toxicities. It can cause kidney damage. It can cause hearing loss. It can cause tinnitus or ringing in the ears and cause low blood counts. And so we're really trying to figure out ways how to maybe not give as much cisplatin or how to avoid that chemotherapy in general if possible. Recurrent metastatic disease represents maybe about 20 to 30% of the patients that I take care of. Most of them are locally advanced cancer patients. But when it's recurrent or metastatic, especially, it's not something that we can cure. And so we're heavily reliant on chemotherapy and or immunotherapy. This is a poor prognosis, as I mentioned. It's not something we can cure. So a lot of work is needed to try to improve upon outcomes for those patients. So for the next few slides, I'm going to discuss locally advanced disease and de-escalation therapies, which are in vogue right now in trials. And then I'll talk about recurrent metastatic disease for the rest of the talk, as I think this is where the biggest need is as far as coming up with ways to help people live longer and feel better. So there are a few different ways to think about de-escalation. I think when we think about de-escalation, this is really, really more for patients who have oropharynx cancers that are related to the human papillomavirus. So one way to think about de-escalation is to try to avoid platinum-based chemotherapy, so cisplatin, because of those side effects. There is an FDA-approved therapy called cetuximab, which isn't a cytotoxic chemotherapy. It's more targeted agent and actually does have some efficacy in helping radiation work better. So that's one option. Another way to de-escalate is either by reducing the dose of radiation therapy for patients who have a really good response to chemotherapy if they get it in the first line, or reducing the dose of radiation after surgery. I'm going to focus more on the first one, first de-escalation, because it's sort of a broad area, and there's a bunch of studies that have been done, but I'm going to focus on two that were done more recently nationally here. So the first study was a phase 3 study. I think it was published last year. It was called the de-escalate trial. So what the de-escalate trial did was it compared cetuximab plus radiation versus cisplatin plus radiation in patients with low-risk oropharyngeal cancers that were a result of human papillomavirus infection. Now, the one thing I didn't mention is that before someone with human papillomavirus gets cancer, it actually takes a good 20 to 30 years. So, people say, how did I get this? I've been, human papillomavirus is a sexually transmitted virus, and they're shocked because they say, well, I've been married for, 30 years. Why did I get this now? And it's because that oncogenic process just takes a very long time if it's going to have a cancer form at the end of it. That's why it's really important to get vaccines, because in the same way that human papillomavirus HPV vaccine is going to help and has helped reduce cervical cancer incidence, similarly, we're, I think, going to see a lower HPV rate as well if that vaccine is taken up by the population. Regardless, so what this study did was they randomized the patients into two groups. The first group got the standard of care. The GY stands for gray. 70 gray is a cumulative dose of radiation. It's kind of how they measure radiation doses. And this is sort of the standard of care. And they compared this with 70 gray with cetuximab. The primary outcome in this study was severe toxicity, and the secondary outcomes were looking at survival and quality of life and swallowing. As you can imagine, when you're getting radiation to your tonsil, that's going to be right near your esophagus and all your swallowing muscles. So it's really important to try to assess that. So I've just briefly put in some of the results. So as you can see, At 2 years, there was a pretty significant difference in overall survival between patients that got cisplatin in this group versus cetuximab. Now, it's low risk, so you may say, well, they got cetuximab and they still had a 90% patient population of survival, which is true. But what I didn't put in the slideshow is that actually what they found was that the uh, adverse events or side effects, and we thought cetuximab would have a better side effect profile. It actually did not. So the side effects, while different, were overall still pretty severe, even with cetuximab and radiation. As you can see on the right side of the slide, the 2-year recurrence rates were also significantly worse for patients who got cetuximab. So as you can see here, 16% of patients had a recurrence rate, and 6% of patients with cisplatin had recurrence rates. This does not mean that those patients were incurable. It just means that the surgery that we try to avoid, which is a pretty major surgery if chemoradiation doesn't work for these patients, they had to undergo, and this is a pretty life-altering surgery because it requires taking out a lot of your tongue, and a lot of sometimes people's voice boxes have to be removed. So it's something that we really try to avoid. And you can imagine if you're giving 98% chance of living and a 90% plus chance of avoiding that surgery, that's probably a good thing. So 94% of those patients were able to avoid that at 2 years. So that was one study that pretty much showed that cetuximab was not good enough. This other study was also done with the same idea in mind, trying to de-escalate therapy, and they compared the same thing. This was an RTOG, so this is a National Radiation Oncology Group, which compared cisplatin with radiation versus cetuximab with radiation. And similarly, as you can see here, there was a survival difference. Patients who got cisplatin at 5 years had better survival compared to patients who got cetuximab, And then same thing with progression-free survival, meaning how long until the cancer progressed. Again, pretty significantly different. So these two studies essentially showed that there was an improved survival for patients who got cisplatin versus cetuximab. There were higher rates of local regional recurrence and failures, and by that I mean the cancer was still in the oropharynx or elsewhere in the lymph nodes versus cetuximab. The higher rates with cetuximab and cisplatin, and there were similar rates of adverse events between the two drugs. So at this point, cisplatin still remains the standard of care for chemotherapy plus radiation in low-risk HPV oropharynx cancers. Now, there are many ongoing questions that remain. There's still a debate on how best to approach de-intensification. As I mentioned, those other 2 bullet points on the initial de-intensification slide, whether to reduce the dose of radiation, in certain circumstances. But either way, more high quality trials are necessary to make clear which new therapy sequences add benefit and in which patients, So at Moffitt, and as is true of most academic centers, we have a bunch of de-escalation trials to see who can avoid some of these side effects. Because as I'll show you later on, some of these long-term side effects are really quality of life diminishing. Now, immunotherapy, immuno-oncologic developments in the treatment of head and neck cancers has rapidly expanded over the past several years, both in terms of standard of care and innovative research technologies. Now, in particular, as I mentioned, the finding that the human papillomavirus is a causative agent for oropharynx tumors has really revolutionized the field because it represents a target. Present studies are varied and range anywhere from evaluating the benefit of preventative vaccines, targeting HPV infection, using therapeutic vaccines. So by therapeutic vaccines, I mean, the concept of a vaccine is basically to try to get your immune system to mount a response to something foreign. Now, therapeutic vaccines try to figure out a way to get your body to recognize that that cancer cell is foreign. There's immune checkpoint inhibition, so things like pembrolizumab or nivolumab, which I'll get into in a bit, and other cellular therapies, which I will talk about at the end of this talk, including CAR T cells, re-engineered TCRs or T cell receptors and tumor-infiltrating lymphocytes, and combining those with other immunotherapies. I think the existing paradigm involving cytotoxic chemotherapy, so cisplatin or other chemotherapies and radiation therapy, is likely to be incorporated into a variety of immunotherapeutic strategies. And while there are more established standards of care for head and neck squamous cell cancers, which is really what I've been talking about this whole time, I haven't even mentioned salivary gland cancers or thyroid cancers but patients with salivary or thyroid cancers that need systemic therapies are also being tested in immunotherapy trials as well. So there's a whole host of things that are trying to figure out how to help these patients live longer and feel better. Now, there are a few currently approved checkpoint inhibitors in head and neck squamous cell cancers. Pembrolizumab and nivolumab are both anti-PD-1 agents that were approved in 2016 for patients with recurrent or metastatic head and neck cancers whose cancers have progressed after traditional chemotherapy. Everybody talks about immunotherapy and checkpoint inhibitors, but I wanted to just briefly tell you all what that means. So PD-1 is a checkpoint, and it stands for programmed cell death 1. It's a checkpoint where it's a protein that's found on the surface of cells. And what that protein does is it actually downregulates a person's own immune response. So traditionally, you need this because if you don't have certain checkpoints on your immune system, people develop autoimmune diseases. So you don't want your body attacking yourself. And that's kind of what happens in things like lupus or scleroderma. And so this is sort of a normal thing. But what the cancer cells have figured out is it's one of the main ways that we believe cancer cells evade the immune system. So you would think that the immune system would be able to recognize a cancer cell as something foreign in the same way that if you got a viral or bacterial infection, your immune system recognizes that as something not you, and so it attacks and kills it. Because of PD-1, along with a whole host of other mechanisms that inhibit the immune system, the cancer cell is able to live freely. So what anti-PD-1 agents like pembrolizumab or nivolumab do is they actually attempt to take that mask off and reveal the cancer cell to the immune system so that the immune system can then subsequently recognize and attack it. So along with pembrolizumab and nivolumab, cemiplimab is another checkpoint inhibitor that is approved by the FDA, I believe in 2018, for patients with skin cancers that are squamous cell that can get radiation or can get surgery. And we happen to see a lot of these in head and neck as well. We see skin cancers that can be operated on or have gotten radiation and come back. And so we tend to give cemiplimab for this. More recently, so just in 2019, pembrolizumab plus chemotherapy and or by itself was approved as first line. So in contrast to the 2016 approvals, this was approved for patients whose cancers had progressed after chemotherapy and radiation. So I wanted to just briefly review the data that supports these FDA approvals in the next few slides. So this was a study that was published back in 2017. It's called Keynote 012, and this was basically using pembrolizumab in recurrent metastatic head and neck cancers. It actually included a bunch of different cancer patients, but there were other cohorts, but I'm going to show the head and neck cancer group. It was a multi-center, non-randomized phase 1 study, and objective response rate and safety were the primary endpoints. So we're going to see this theme a lot in the next couple of slides, but basically what you need to take from this is that immunotherapy works, but it only works for a small amount of patients, and generally when it works for a pretty long time. So the objective response rate here was about 18%. So 4% of the patients, CR stands for complete response, PR stands for partial response. Complete response means that there was no longer any evidence of cancer seen on a scan or clinically. PR means that there was a greater than 20% reduction in someone's tumor burden. Now, the figure on the left of the slide demonstrates overall survival by HPV status, and the 6-month overall survival rate was about 70% in patients with HPV-associated disease and about 56% in patients with HPV-negative disease. The figure on the right demonstrates responses amongst the patients. They call this a waterfall plot. And interestingly, the median duration of response was not reached. So what does that mean? Basically, what that means is that the people who responded kept responding, and at the endpoint for the study, some of them were still having either complete responses, so no evidence of cancer, or their cancer was still getting smaller. So this is pretty great, even though it only worked for a small amount of patients. This was another study of, so based on that initial study, they did another study in head and neck cancer in particular. This was a phase 2 trial for patients with head and neck squamous cell cancers who had progressed, whose cancers had progressed on platinum and cetuximab. And the primary endpoint here was, again, objective response rate and safety. And what's notable about this also is that 75% of patients had more than 2 different lines of chemotherapy for their disease. So these were patients who were multiply refractory to other treatments, or whose cancers were multiply refractory to multiple treatments. So similar to that first study, the overall response rate was low. It was 16%, but with the median duration of response, that was about 8 months. So that was longer compared to what was expected from traditional chemotherapies. Overall survival in this case did not differ by HPV status. So again, sort of proving the same point that it works for a small amount of people. If it works, it tends to work for a pretty long time. This is another study called Checkmate 141. It was a study of nivolumab versus chemotherapy for patients with recurrent metastatic disease after exposure to platinum, so something like cisplatin. Similarly, the response rates to nivolumab here were only about 13%, but there was a statistically significant impact on survival, and so 7.5 versus 5.1 months. Now, you may not think this is significant, but it was statistically significant, but really is it clinically significant. I think what's nice about immunotherapies is that for the most part, they tend to be much better tolerated than the chemotherapies. And in particular, all of these chemotherapies have pretty significant side effects, including the cetuximab, which isn't such a cytotoxic chemotherapy, as I mentioned. But it tends to be much better tolerated. And the fact that it actually resulted in a pretty small but significant survival benefit was really great, just for tolerability's sake. I won't belabor this point, but this is cemiplimab's data for cutaneous squamous cell cancers. And this actually had a pretty significant response rate, of 47% in patients with metastatic disease, and 60% in patients with local advanced disease had an objective response. So as you can see, this waterfall plot, basically everybody to the right here had either stable disease or pretty significant response rates otherwise. Now, the prior few studies established that immunotherapy could work for patients with multiply refractory disease, especially in head and neck squamous cell cancers. What's interesting about that is that head and neck tumors were long believed to be what we call immunogenically cold. Basically, they thought the immune system had nothing to do with these tumors, and that modulating the immune system would not work for these types of cancers, unlike in melanoma or Merkel cell, which is another sort of skin cancer. As I mentioned, the response rates in those prior studies were low, but for the patients for whom it worked, it tended to show durability in those responses. Now, the use of checkpoint inhibitors in multiply refractory disease theoretically proved problematic because when patients get lots and lots of chemotherapy, those T cells, their lymphocytes that are hopefully attacking those cancers after immunotherapy is given, they could be really exhausted, they may not work as well. So this study attempted to see what would happen if it was employed earlier in treatments rather than waiting till patients had gotten chemotherapy significantly. So this was a study of pembrolizumab versus pembrolizumab plus chemotherapy versus something called the extreme regimen. This was a study that was published in the New England Journal several years ago, I think over a decade ago at this point. And this was our go-to treatment paradigm for patients with a metastatic disease. And it was a combination of platinum or carboplatin or cisplatin, something called 5-fluorouracil, which is usually given by a pump, and then cetuximab. The response rates for the extreme regimen were about 36%. So it only worked 36% of the time, and it was extraordinarily toxic. And anecdotally, when I try to give my patients this combination of chemotherapies, it's just very hard to tolerate. So it doesn't seem to help quality of life when I take care of these patients that I had to get through this. And it only tended to, the durability of the response to this was only about 4 to 5 months. It wasn't very long. So we were looking for something to hopefully be better tolerated. Now, median overall survival was significantly increased in patients who received pembrolizumab plus chemotherapy, as you can see on the left side. And the overall survival was also non-inferior for patients who just got the pembrolizumab. The side effects were really driven by the chemotherapy here. So there wasn't much difference in side effect profiles between these two. There was a pretty significant difference between side effects with just pembrolizumab alone versus extreme. As you can imagine, pembrolizumab is much better tolerated. It can have some immune-related adverse events, but they tended to be minor and very easily tolerated and managed, quite frankly. I should mention that just logistically and for quality of life for patients who are undergoing these therapies, this takes about 4 to 6 hours to infuse, patients have to come back to get their pump disconnected for that 5-fluorouracil that I mentioned. So it's another visit. This is a 30 to 60-minute infusion and given once every 3 weeks. So, this is also given every couple of weeks, but as you can imagine, this is a whole host of quality of life issues that are worse with this. So this is a summary of overall survival for that study. CPS is a way to assess that PD-1 that I mentioned, that receptor on these cells. And what they basically found was that pembrolizumab plus chemotherapy improved overall survival in the CPS greater than 20, greater than 1, and in the total population of patients studied. And pembrolizumab alone helped people live longer if their CPS was greater than 1 or greater than 20. And it was no different between extreme in the total population. So you think, well, even if someone's CPS is not 1, you could argue that if it was not inferior in the total population, you could say, and it's much better tolerated and quality of life better. Quality of life is better with this. It's probably better to do than that chemotherapy regimen. So this was FDA approved for first-line management of these patients now. And this is kind of what we use in a day-to-day clinic practice. What these studies did was provide a proof of principle that the immune system could be harnessed and employed for disease control or reduction in head and neck tumor sizes. And while cell therapy, I'll get into in a little bit later, I think much of the field is going in this direction, especially since we know that higher T cell infiltrates are indicative of a better prognosis. So what I mean by that is that when some basic scientists have taken these tumors, so taken biopsies, what they found is that the patients that do better are the ones who have more of their own lymphocytes infiltrating the tumor. So that makes us think, well, okay, if we can just improve upon the effectiveness of those lymphocytes, those T cells, maybe we can figure out why those patients do better. And maybe we can figure out for patients whose lymphocytes are not there, if we get them there, maybe those patients will do better than too. Then this is why biomarkers are really important, because PD-L1 is not a perfect biomarker. I've had patients with CPSs of 100 who have had not good responses to immunotherapy, and patients whose CPSs were 1 and who had a complete response, meaning their cancer melted away. So it's really important to figure that out. And when we look at the data from prior, looking at the 2-year update for that nivolumab study, really what they found was that PD-L1 expressors did do better on their study, and overall survival was better, but it's not a perfect biomarker. So it's something that we really need to figure out who responds and why, because it's really those minority of patients that are responding. There is some rationale, as I mentioned before. I believe the future will be incorporating the standard of care with radiation and maybe even other chemotherapy with immunotherapy. There's some data to suggest that radiation can help do that. So radiation, when you radiate a tumor, that tumor secretes a bunch of hormones and antigens, and hopefully the immune system can be harnessed to recognize those things that are released to attack the tumor after radiation is given. So there's a bunch of national trials that I've listed here that are studying just that combination of radiation and immunotherapy. So as I mentioned, a significant number of patients don't benefit from these immunotherapies. So what is cellular immunotherapy? Well, cellular immunotherapy is something that I'm very much interested in, and it's a type of immunotherapy in which immune cells are given to a patient to eliminate their cancer. So this is also known as adoptive cell therapy. And I'll briefly talk about the 3 different types of major adoptive cell therapies that have been studied since the 1980s at the NCI. Chimeric antigen receptor T cells, we call these CAR T cells. These are the only approved by the FDA agents for treatment as far as adoptive cell therapies are concerned. They're only approved right now for certain types of lymphomas, and I'll tell you what these are in a second. The second thing is tumor infiltrating lymphocytes as a therapy, and then engineered T cell receptors. So before I get into all that, I wanted to say why head and neck cancers. Well, as I mentioned, in contrast to what was believed to be a cold, immunogenically cold tumor, something that wouldn't respond to immune modulation, it's actually known now that head and neck tumors are very inherently immunogenic, and especially those HPV-associated cancers. I mentioned that tumor-infiltrating lymphocytes have demonstrated a prognostic value in both HPV-positive and HPV-negative tumors, and this suggests that immune manipulation may be a viable anti-tumor strategy. And HPV-16 viral antigens, so as a result of those oncoproteins that I mentioned, are important for the survival of HPV-driven cancers. And what's nice about this is that they're only found in those cancer cells. These viral antigens are not found in normal tissue, which makes this a very attractive target for anti-cancer therapy. So this is a general schema for the use of adoptive cell transfer of naturally occurring autologous tumor-infiltrating lymphocytes, or TILs. Now, I want to be clear and transparent that this is way far into the future, but I think it's really exciting, and I think it builds on immunotherapies in general. So I wanted to briefly mention it because I think a lot of different cancer researchers are talking about trying to apply these same logic to the cancer that they study or that they treat. So basically what it is you excise a tumor. So you ask a surgeon to excise a tumor in a patient with metastatic disease. You take that tumor and you isolate those lymphocytes that the body has sent to try to fight the tumor. Now, usually they don't work. Obviously, you may think, well, if they're already there, why aren't they working, right? Your body's already sent those lymphocytes to those tumor cells. Why isn't it killing the cancer? Well, a part of it is it's gotten there, but it may be weak because that tumor environment secretes a bunch of inhibitory mechanisms and hormones to try to prevent that lymphocyte from working. So it's kind of exhausted. So what they do is they isolate those lymphocytes, they culture them and they grow them, and then they figure out whether the ones that they've grown and expanded outside of the body are effective in killing that tumor or recognizing the tumor. Once they've identified the ones that have the most specificity for tumor, they expand those and then reinfuse them after giving chemotherapy to the patient. So I know we're talking about head and neck cancer, but the data for that is still pending. But this is what I wanted to show you was a study that was presented last year in ASCO, the American Society of Clinical Oncology meeting, for melanoma. So melanoma is very, very immunogenic, very susceptible to immune modulation. And what they did was just that. They took a tumor specimen, they isolated those lymphocytes, they expanded them outside of the body, and then refused them. What they found was that 81% of the patients given this therapy, and this therapy was given to metastatic melanoma patients who had progressed on multiple different chemotherapies, or whose cancers had progressed on multiple chemotherapies. And what they found was that 81% had a reduction in their tumor burden, which was astounding. You can imagine after getting 3, 4, or 5 lines of chemotherapy. There was a similar study done in cervical cancer patients, which found a 44% objective response rate. So, the time that patients either had their cancer completely melt away and or significant decrease. What's interesting about this slide is that really a lot of patients had a pretty significant, so the light blue is, or aqua, I guess, is partial response, and the green is complete response. There's something unique about these patients and their tumors that made them respond. And we don't quite know why, because obviously if we knew why, we would make that applicable to everybody. But it's really pretty exciting business to try to figure out why some of these patients had such great response. This was another study of autologous TILs for advanced melanoma, kind of showing the same thing. For head and neck cancers, for TILs, so there was a phase 2 multi-center prospective study of autologous TILs that's currently ongoing. The data is pending. It should hopefully be presented in the next year or so. But given that data in melanoma and cervical cancer and the inherent immunogenicity of the head and neck cancer, this represents a potentially promising cell therapy. Now, what's difficult about this is that this is extraordinarily expensive. It takes, you have to have a patient fit enough to undergo a surgery to get that tumor excised. The manufacturing time sometimes can take 3-4 weeks. Then you have to admit the patient. They stay in the hospital for 7 to 14 days sometimes. So I'm not sure how generalizable this will be until the processes get a little bit more streamlined. But if it works, and I think it's going to, at least it has worked, I think, at least preliminarily for those studies on melanoma and cervical cancer, we'll see what it is for head and neck cancer. But if it works, then I think the goal will be to try to figure out how to actually generalize it. So you may think, well, okay, those lymphocytes are already in the tumors, and they have recognized the tumor, but they don't affect any change because they're exhausted or dysfunctional. Well, what about taking lymphocytes from your bloodstream, because they're lymphocytes at the end of the day, and re-engineering them to try to target something? So this is exactly what CAR T cells and TCRs are, T cell receptors are. As I mentioned, CAR T cells are the only approved agent right now, and they're really only applicable for lymphomas, but this same process is trying to be used for solid tumor cancers, and in particular head and neck cancers. So TCRs, they recognize intracellular proteins. CARs tend to recognize things that are expressed on the cell surface. That's really the biggest difference, excuse me. It's hard to develop these for solid tumors because unlike in patients with lymphomas, which tend to have a little bit more homogeneity in what they express on their external environment, solid tumor cells, the one in your chest may be different than the one in your liver, may be different than the one in the bone, so it's a little bit more heterogeneous. Now, this has already been studied a little bit in patients with HPV-associated cancers. This was a HPV TCR. So what they did at the NCI was they developed a TCR to target a particular protein that was unique to HPV infection, and they gave patients that T-cell therapy. Now, as you can see here, I think the other two pictures are a little bit hard to see here, but this is before treatment where you can see all this cancer lighting up, particularly in the lungs, and this is 3 months after treatment. So really, really significantly reduced that cancer burden. So there are a few, and I should say that there are a lot. I've just listed a few here, current TCR and CAR T-cell clinical trials for solid tumors that are ongoing. But I think time will tell whether these are going to be effective or not. The last thing I didn't show in trial for, but that is pending is, head and neck cancers tend to be pretty accessible surgically. So if there's something that is unresectable, but at least accessible, and you develop a CAR T-cell or some environment to try to inject it, then that would be a perfect cancer type to try to apply this to. And there's already some intratumoral CAR T-cell clinical trials where they're developing these T-cell, receptors or CAR Ts and then injecting them in tumors to see if that affects any change. So I've talked a lot about clinical trials and where I think the field is sort of going, but as I mentioned earlier, there's a lot of psychosocial concerns for these patients as well. Definitive treatments, which are long, 6-7 weeks, sometimes radiation or surgeries and chemotherapies are difficult to tolerate, leaving many patients with long-term functional and psychosocial challenges. It's actually one of the saddest things about head and neck cancer patients, but also one of the things that makes me interested in it because I think there's a lot to do and a lot to change. You can imagine if you take away someone's ability to talk, to eat, to speak, you've taken away a lot of, how they interact with the world and how they enjoy the world. So it's really challenging. Cancer survivors even end up with chronic symptoms either from radiation or chemotherapy or surgery, and they have functional impairments. On top of that, there's changes in appearances. You can imagine if your tongue is removed or if you have radiation to your neck, that can diminish quality of life. And it's actually known that head and neck cancer patients have a very high suicide rate. They have a suicide rate that's 3 times the incidence compared to the general US population. And I believe there was a study presented a few years ago which just took cancer survivors or cancer patients, and what they found is that head and neck cancer patients have the second highest suicide rate of any other cancer type. And I suspect that's because of those things I just mentioned, of the long-term functional and psychosocial challenges that come with even being cured of this disease. So more help is needed in figuring out how to help those patients, not only dealing with short-term side effects, but long-term sequelae of their head and neck cancer diagnosis and treatment. And this doesn't even mention the fact that usually when these patients undergo these 2-3 month long radiation regimes, that their caregivers really bear a brunt of the treatment as well, because they really have to be there to help take care of those patients for a very long period of time. So there's a lot of caregiver burden and stress that goes along with undergoing these definitive treatments. So in conclusions, cytotoxic chemotherapy is a mainstay of treatment for locally advanced disease with radiation, but for metastatic disease, it really achieves limited survival with unfavorable side effects. Those checkpoint inhibitors I mentioned are approved now for patients with head and neck cancers in certain circumstances, but it really only tends to work for a small amount of our patients. For whom it works a really long time. So ongoing areas of research include combining these with radiation or other drugs, developing those different types of cellular immunotherapies and predictive biomarkers, and trying to figure out why 80% of our patients with immunotherapy, why their cancers are resistant to what we give them. And lastly, a lot of work is needed to try to improve upon quality of life, supportive care for these patients, because they really undergo a lot, even if they get cured of their disease. So I want to thank everyone for listening. Hopefully it was relatively short and sweet, and I appreciate Elevate Cure for asking me to talk today. And I'm open to any questions or comments.
Thank you, Dr. Kirtane. I actually learned something, a lot of things new, but did not consider the psychosocial concerns. That was not something, on my radar as far as, for patients of head and neck cancers. So it's interesting. Are there any specific research that's happening currently on the psychosocial front, or that we know of, or?
Yeah, so there are a lot of studies. I mean, I think nowadays, national trials have done a better job of incorporating quality of life measurements into their trials, because
Yeah.
you can imagine if you're worsening quality of life, especially in this population, it's not survival and things like that are also on the same level, I think, viewed. Um, I know some colleagues that are doing financial toxicity work for these patients, because going through 2-3 months of therapy, they have to leave their jobs. I mean, you can't work while you're getting these therapies done.
Yeah.
So there is a lot of stuff going on, but it's still trying to figure out how to help them supportively.
Great. Are there any
You know, I
questions
I'm
from? Oh,
surprised
sorry.
that there aren't a lot of places don't even have head and neck cancer support groups.
Programs,
So,
yeah.
they kind of get lumped in. And so it's really important, because I think the incidence is rising on some level. And it's one of those things where there's not a lot of patients, because it's only 5% of US cancers, but the patients who undergo these therapies really need a lot of help.
Yeah. Something for us to consider as we also look at other programs that Elevate Cure Foundation can support. Are there any additional questions for Dr. Kirtane from the attendees? As I mentioned, we have recorded, and this will be available on the website, and I'll send out an announcement for anyone, and please feel free to reach out to me directly with any questions. And if there are any additional questions for Dr. Kirtane and you just want to ask it by email, I can certainly forward it to him offline. So with that, we wanted to thank everybody. Thank you, Dr. Kirtane, for this very informative session, and I look forward to having you again as a speaker for our webinar series. Thank you,
Awesome. Thanks so
everybody.
much.
Have a great
Bye.
day.